sort of overdose prevention alarm in some of the higher risk bathrooms at the institution, and then talk a little bit about sort of acceptance from public safety personnel in responding to overdoses in those bathrooms. So let me just make my screen a little bit bigger here. Okay, great. And so we're really going to be focusing on a paper that will, or is currently e-published, but will be out in February, opening the door to somebody who has a chance, the experiences and perceptions of public safety personnel towards a public restroom overdose prevention alarm system. So Eric and I collaborated on this, as well as with Sarah Lipson, Mary Lynn Drainoni, and Alex Walley. And so this project really came about when we noticed an opportunity to prevent overdoses at the hospital. Nationally, we've seen opioid-related overdose deaths increase 200% since 2000. Recently, we've seen increases in overdose deaths, at least in Oregon, related to COVID and to fentanyl in the drug supply. And so we really noticed that there was a need for responses to overdoses. And the reason for this is, now that fentanyl is in our drug supply, the time that we have to respond to an overdose before it becomes fatal is much shorter. And currently there aren't places where people can safely use drugs, aka supervised injection facilities, that are legal in the US anyways. And so, it's been written about in the literature that individuals who use drugs often use in the bathroom. The reason for that has been postulated to be that there's privacy in the bathroom, there's access to clean water in the bathroom, there's good lighting for performing the injection, and we're also seeing, because there is use of substances in bathrooms, seeing overdoses in bathrooms. And really the question that came up is, how can we, or can we try to prevent some of these fatal overdoses from happening in the bathrooms? And so we first started by looking at overdoses at Boston Medical Center, which is an urban academic medical center. It serves a safety net population. And you can see these are overdose data from our public safety personnel, who are the first responders on campus, that we saw a doubling from 2016 to 2017, and then continued to increase in 2018. And I'm sure that they're still seeing this rate, if not more overdoses at the institution now. And so the solution that we came up with, we borrowed this from Boston Healthcare for the Homeless across the street from Boston Medical Center. They implemented a device similar to this, where when someone goes into the bathroom and closes the door, a motion detector turns on. And if there's not motion in the bathroom for a set period of time, then an alarm goes off, alerting public safety personnel or whoever is responding in the area that there might be someone in distress in the bathroom. And so that therefore would theoretically reduce that risk of someone being not found and then resulting in a fatality. And so once we decided that this is what we wanted to implement, I met with stakeholders at the institution. So I met with public safety leadership to make sure that they were on board with implementing something like this in some of our higher risk bathrooms. I met with hospital leadership and the patient safety team, as well as risk management, to get funding for initiating this. And then I also met with addiction medicine leadership and other people on the team to sort of see if we could study this. And so more specifically to the anti-motion alarm system at the institution. So we isolated 3 bathrooms that had the highest fatality rates. So there were, I believe, 3 fatalities in these bathrooms. And the reason for that, I postulate, is that you did not need to swipe in to get to this area of the hospital. Anyone could access it off the street. And it was in a sort of secluded corridor to the side, that there was not a lot of traffic. And so people could easily go in there and not be disturbed, but then also not be found if they had overdosed. So our system was a little bit different than the one at Boston Healthcare for the Homeless. Their system, when you close the door, there were 2 metal plates that sort of connected, and that triggered the initiation of the timer. We couldn't figure that out in our situation. And so we actually triggered it to the deadbolt that was used to lock the door. And so when you close the door and turn the deadbolt, that's when the timer started. There was a motion detector up on the wall, which you can see down here. And let me get my pen here. And I can show you, there we go, yeah. So here is the motion detector. And then if there was movement every 4 minutes, which is sort of just a time that we chose, then the alarm didn't go up. It would just continue to reset until the deadbolt was unlocked. But if there was 4 minutes where there wasn't any movement, then the alarm would sound not only locally at the bathrooms with a strobe light over the individual bathroom that was having the alarm go off, but it also set an audible and visual alarm down to our security desk in the lobby. These bathrooms were sort of on the 2nd floor in a giant open atrium. And then thirdly, it would trigger a remote alarm sent to public safety dispatch. So if for some reason no one was in the building to hear it or see it, public safety would still get an alert saying that the alarm is going off, so someone could go over there and check it out. And so the alarms in our building were silenced by 3 different mechanisms. So if someone started to move in the bathroom, the alarm would go off. Like I had said, if the bathroom door unlocked, the alarm would go off. And then you can see down here in the bottom right-hand corner, there was a manual reset that you could open and push. And so the alarms were silenced usually after the officer had gone and reported that everything was all clear. Okay. And so once we had the alarm system implemented, we had to come up with a way that officers would respond to this. And so this was the standard operating procedure that we had developed. And so the alarm was triggered, and then there were 3 different options. So, we brought in our guest support staff as well. They sat at the same information desk down on the 1st floor that our public safety officers were often sitting at. But should the alarm go off and the public safety officer wasn't there, they would just call 44444, which was our sort of number for public safety. If there was an officer at the desk, they would sort of radio to dispatch, and they would be the ones to respond. And then again, if there was no one at the desk or no one hearing the alarm going off, then the dispatch center would notify the closest public safety officer. And when the officers went to respond, they actually would take this bag that they had that they would normally respond to overdoses with. It had Narcan, it had an ambu bag, and then a few other things for just first aid. And so then once they got up to the area where the alarm was going off, they could see which one was going off based on the strobe. So they knock on the door. If the person responded and said, oh yeah, I don't know what's going on, I'm moving, everything's fine, then they would just sort of unlock and relock the bathroom door, which would deactivate the alarm and then restart it, then let them know that, this bathroom had a special alarm that if you didn't move for 4 minutes, that the alarm would continue to go off, and then they would fill out a report in their QED reporting software. If for some reason they knocked on the door and there was no response, then they would alert the patron in the bathroom verbally saying, I'm going to open the door, which would deactivate the alarm, assess the patron for signs of overdose, administer naloxone if needed, call 911, because this, even though it was part of the hospital campus, it wasn't technically in the hospital, it was in a building next to the hospital. And so we didn't have a code team in that building. So they would call 911 and then initiate rescue breathing per their protocol. And then at the end of that, also complete a report in their QED reporting software. And so how did we disseminate this information and train the public safety personnel? And so there are two different things that we did. I went to their change of shift. So every, I think it was 6 a.m., 3 p.m., and 11 p.m., they had a change of shift meeting for all the officers. And so I just did sort of 3 days in a row, went to all three of those and gave a short 10 to 15 minute presentation, sort of highlighting the SOP. And then on top of that, we put together a longer PowerPoint slide set looking at not just the SOP, but also why people use drugs in the bathroom, sort of a little bit about addiction as a chronic disease, information about the anti-motion alarm system, and all new hires and current employees in public safety had to complete that online training, and there were 4 or 5 questions at the end. So that was a little bit about how we implemented the devices themselves. And so I'm going to hand it over to Erica, and she can talk a little bit more about how we studied the responses of public safety personnel.
Okay, just one second, let me share my screen. Bradley is much more facile with PowerPoint and screen shares than I am. But Bradley, there's a question in the chat about how well the alarm was. Do you want to answer that while we do this?
Sure, let me open up the chat here. Okay, yeah, so the alarm was quite loud. You could hear it. So if it went off on the 2nd floor, you could hear it outside of the building. It was, I would say, equivalent to a fire alarm in that localized area.
Great. Okay, so I think you should see my study aim slide up now. So as Bradley mentioned, it was great that the hospital wanted to implement this, and we were certainly curious if it would help prevent overdoses, but we were also aware that no research had actually been done to assess the impact of overdose response interventions on public safety personnel who aren't medical first responders, right? But these individuals are likely the first on the scene when the alarm goes off. So the primary research aim was really to understand the experiences and attitudes of public safety personnel who responded to potential overdose alarms in the hospital setting. And we were specifically curious how the public safety personnel at our hospital perceived the anti-motion detector alarm and how it was impacting their daily workflow. So given those kinds of aims, we designed a qualitative study and conducted individual interviews with public safety personnel at the hospital who had responded to an overdose in the last year and who also had responded to the anti-motion alarm in the first 3 months of its implementation. We did semi-structured interviews that lasted about 30 minutes. And we had a multidisciplinary research team, as Bradley mentioned, and that included physician experts in addiction medicine like Bradley and Alex Walley, as well as health services researchers with qualitative expertise who study the experiences of individuals with substance use disorders and also study justice-involved health interventions. So together, our team developed and refined the discussion guide that we use to interview public safety personnel. So a bit more about the guide. It included a few different sections. Participants were asked to walk us through their past experiences responding to overdoses at the hospital, both pre and post the alarm implementation. We asked participants what they were thinking or feeling mid-response as well as post-response. And we asked more targeted questions like to what extent they felt like responding to overdoses was an appropriate part of their job duties and how the alarm impacted their workday. We also asked questions to better understand their emotional response to the alarm. So we asked how the alarm impacted their well-being, how they, how often they think someone is in the public restrooms at the hospital using drugs, and how that may also impact their response time. Participants who completed the interviews also were asked to complete a demographic survey. We collected basic information like their age, sex, how long they'd been employed at BMC as a public safety officer, and how many overdoses they'd responded to in their lifetime. So we just computed basic frequency statistics to describe the survey data and demographic characteristics of our participants. The interviews were professionally transcribed and then analyzed by 2 qualitative researchers. So we used thematic analysis with inductive methods from grounded theory, which basically means that we read and reread and reread transcripts, developed qualitative memos to highlight emergent constructs and ideas from the data related to our research aims. So things about emotional response, time to respond, workday tasks, things like that, acceptability. And then 2 researchers met to review the memos, and we developed our initial code book. And then we used that code book to double code transcripts to achieve consistent and also reliable application of the coding across the rest of the interviews. And then we reviewed all of the coded data to elucidate our themes, which were refined and finalized through consensus discussions. So here's a snapshot of who our participants were. We interviewed 11 public safety officers, and it's a small sample, but remember, qualitative analysis relies on thematic saturation to determine sample size, not power calculations. So we found that after 11 interviews, we really were starting to hear the same things over and over again, and thus had reached thematic saturation. Most of our participants were about 40 years old, male, and had been working at BMC for about 12 years. Participants had responded to anywhere from 1 to more than 20 overdoses in their lifetime, and about 64% had responded to a fatal overdose in the past. So selection criteria, you'll remember, it demanded that participants have experience with overdose response in general, but also with the anti-motion detector. And when we asked them at the time of their interview, most people had responded to 11 or more alarms in the last 3 months. So we identified 4 themes describing public safety personnel's experience with the alarms and overdose response. And here's just a quick overview before we dive in. So first, they believe that responding to overdoses is an appropriate job responsibility. Public safety personnel also described that they focused on their job training rather than their individual emotions when responding to an overdose. They view anti-motion alarms as an acceptable tool to prevent overdose, despite some technical flaws in the alarm system. And public safety personnel are concerned about some potential unintended consequences of having the anti-motion alarm system, which I'll discuss. So first, across participants, there was no question that they believed responding to overdoses was an appropriate and acceptable job duty. They said they were often the first on the scene in a life or death situation where there was no time to wait for medical personnel. As this one participant said, 100%, it's completely part of the job. There's no ifs, and, or buts. Participants also said they needed to be trained in naloxone administration and overdose response. As this individual noted, I think it's a real need for us to be able to do that rather than stay on the sidelines. I mean, we're here at a hospital, so obviously there's amazing medical staff here. But if we're first on the scene, we got to do what we got to do until somebody higher trained than us can kind of get on the scene. Here's the second theme, that they really felt that the alarm system was an acceptable tool to prevent overdoses despite some challenges. So once public safety personnel, I'm looking at a different slide. They really focused on their individual training in the moment rather than their individual emotional reaction when they respond to an overdose. So once they actually were able to transfer the care of a patron who experienced an overdose to the medical team that responded, that's when their own emotional response started to kick in, and there was a bit of a tension between feeling accomplished for preventing a death, saving a life, but also feeling somewhat frustrated because in many cases, participants described reviving the same individual multiple times. So there's some illustrative quotes here that are kind of helpful. It made me feel rewarded that I'm able to save somebody. because it's a human being. And that really speaks to sort of what do we as humans need to do to prevent a death, right? But on the flip side of that, we also heard a lot of things like this comment in red. You definitely get frustrated because there have been times that we've Narcaned someone first thing in the morning, they've left, and by the afternoon, we've Narcaned them again in a different building. So participants really describe sort of oscillating between those two feelings. Okay. Beyond describing the overdose response as an appropriate job responsibility, overall, public safety officers really liked the anti-motion alarm and felt it was an acceptable tool in the hospital setting. They didn't perceive the real or false alarms as a hassle or burden to their daily routine. One participant said that the alarm gave an indication of how long someone had possibly been experiencing an overdose. I know if it's only been a max of 4 minutes, I'm not going to open the door to somebody in rigor. I'm opening the door to somebody who has a chance. However, participants also said that the alarm was easily triggered by people using the restroom for non-drug use purposes. So identifying this kind of a shortcoming, the sort of false alarms that happened a lot, this led officers to start brainstorming some potential solutions that they shared with us, such as extending the timer length beyond 4 minutes, or including a warning sign that the alarm would sound if no one was sort of moving in the space. And then finally, the fourth theme, which is related to the last, is that participants identified some unintended consequences of having an anti-motion alarm. They weren't concerned, as I said, about the false alarms. Rather, public safety personnel said that they found themselves sort of patrolling other restrooms and areas less frequency out of fear that they wouldn't be close enough to respond to an alarm. So one officer said, "We find ourselves more isolated towards the desk in the lobby, anticipating an alarm going off." Officers also said that once patrons learned about the alarm, they might end up using drugs elsewhere on campus where there is no alarm, and there's also less frequent patrolling, which could lead to more fatal overdoses, and that frightened officers. So as this one said, "I'm also afraid that if I'm right, at least the cop side of me, the overdoses in the area are going to spike through the roof and not be survivable ones, because we're going to displace people to tucking into where they are not seen." So all in all, just wanted to share a couple takeaway points before we open up for discussion. Basically, we found that public safety officers feel sufficiently trained to respond to overdoses, and that responding to overdoses is not only an acceptable and appropriate job requirement, they felt prepared to do it, and they did feel a sense of success and accomplishment when they did it, as well as having that tension of sort of frustration of responding to the same individuals repeatedly. That said, anti-motion alarms are not a be-all, end-all. We identified a few unintended consequences, such as displacing people who are using drugs in non-alarm restrooms, and also officers feeling sort of tethered to the area. So we need to think of additional creative ways to prevent and quickly reverse overdoses across the hospital setting. And again, the technology can be improved, whether it's changing the timing of the alarm or posting a warning. I think that's something to think about going forward. So I will pause there, and thank you again for this opportunity to share this really cool research project we did.
Excellent. Thank you both for a fantastic discussion, hopefully an additional discussion, but I just put to folks in the chat, if you don't have an audio capability, feel free to pose your questions to the speakers in the chat. And otherwise, if you have a question, if you want to go on camera and raise your hand, that's another way. But let's see. Thank you. Okay, let's see. So we have a question from Matt about for the facilities where there are no stationary desks, can the AMAS alerts be sent to a smartphone via text, call, or an app? So some technical question.
Yeah, I think that that's probably a possibility. So my understanding from the way that it worked, so we had an electrician that just came in and sort of jerry-rigged what we wanted to happen and made it happen. There weren't like plans that they were following, or there weren't something that we just purchased off the shelf. And so my understanding is the way that the alarms triggered dispatch was via a wireless alert. And the reason for that mostly had to do with the cost of hardwiring the alarm to public safety sort of dispatch. And so I would suspect that if we could do a wireless alarm to dispatch, that it might be possible to do a wireless alarm to a smartphone or something along those lines.
Since you said the magic word of cost, do you have a sense of what the cost of the systems are for any given one space?
Yeah, I would say they were about $2,000 to buy parts and be installed. I think we were using a pretty large electrician firm that the hospital used. So I'm guessing that you could probably get labor a little bit cheaper if you were using a smaller electrician company. But that's, I think, like $2,200 is what we budgeted for each of the alarms.
Great. And then there's another question about false negatives. Were false negatives a possibility with the system?
Yeah, so we didn't specifically look at the alarm system themselves and tried to figure out the false positive or false negative rate. I think that there always is a possibility of a false negative. I think that would be a great second study. The reason why we chose just to look at acceptability first was to see if this was even worth expanding to other parts of the hospital. I think study part number 2 would be a quantitative analysis looking at false positives, false negatives, number of lives saved. I can tell you in the 9 months that they were up and running at BMC, there were 3 overdoses where individuals were found down and not breathing, and then were brought back with Narcan. And we did not have any further deaths in those bathrooms. But again, that was a fairly small time period, and we weren't specifically looking at that data.
Great. And then there's a question also, this relies upon the deadbolt being activated and locked. Having used those restrooms and also gone to the cafeteria, it's often, since it's right next door, the deadbolt lock would often be locked. But this is a really important question for any other site I imagine. Were there any overdoses while the deadlock was not locked?
Yeah,
and therefore wasn't activated?
Yeah, to my knowledge, there were not. It was, so I was really pushing for the institution to do something similar to Boston Healthcare for the Homeless, where they had like 2 metal plates, and when the plates came together, that sort of activated the circuit. And then, once the door closed, then the alarm would start, or the timer would start. Unfortunately, the electrician that we had just said that that wasn't a possibility in the bathrooms that we were at. And so I do think that left this area open to individuals who may not want to lock the bathroom, or if they knew that once the deadbolt was thrown, it could potentially trigger this alarm system to start, then they may not lock it. So I think that that's definitely an area for further research, and I think it might be worth looking at data from Boston Healthcare for the Homeless.
Yeah, I think, just looking at some of the comments and reflecting on what Bradley had talked with some of the officers about, one of the missing perspectives here is the perspective of the patrons who use the bathrooms to inject drugs, right? And that's a critical voice. And that's a whole different discussion about why that voice is hard to include in research, especially in a quick sort of evaluation project like this. But it's certainly a voice that needs to be heard and talked to, and for future research, so we know how to better implement these types of anti-motion alarms, or think about alternatives that would make people, not less likely to we want them, if they're going to use in public setting, we want them to be in a place where there's going to be someone who can respond quickly, right? That's the end goal. We don't want to shame or stigmatize them or push them to a place where there is not quick access to help. So we need to figure out, like, what's the deal with the timer? What's the best way? Is it locking? Is it sort of the magnetic plates that Bradley talked about? Or is there another mechanism that can promote their use of these spaces in a harm reduction perspective?
I can't recall if you mentioned that, but I think maybe it was at the end, perhaps some of the staff had suggested, but was there messaging actually to patrons that this to kind of settle an expectation that the space was equipped with an alarm?
So there was a small like laminated piece of paper on the door that said that these bathrooms were monitored for motion. And that's sort of what the institution had decided. As far as wording, it was like pretty strict, because, you know, we didn't want to say that they were monitored, because then people would imply that they might be video recorded. And so we ended up just saying something along the lines of, these bathrooms are being monitored for motion. If you don't move within 4 minutes, then an alarm would potentially go off. And that was the extent of the information that was given to people who use those restrooms.
Great. Thank you. Brandon, yeah.
Yeah, no, I think this is such an interesting study. I had a few thoughts. One, just as an aside, it would be interesting to randomize the times, like 2, 4, and 6 minutes or something over time to see what the effects are. But I know some of Tracy's research shows, at least with naloxone administration, that the more the first responder does it, the more cynical they get. And so I was thinking about maybe a social desirability bias in the initial interviews, like, hey, my hospital, I'm not going to tell researchers that saving people's lives is a bad idea, but it'd be interesting to go back in a year or so and see if the first responders still feel the same. And the last thing I was thinking, I think displacement shouldn't be underestimated. I think some people, their whole goal is to remain fairly motionless after they've injected drugs. And if they're there to sort of like enjoy their high, and they find that after 4 minutes or so they're getting moved along, it may not have been that they were overdosing. It may have been that they achieved the exact state they wanted, and now they know they can't safely inject there anymore. And that goes back to the idea that Erica was saying about talking to the people who were using the facilities. I just think that's a serious. If the effect is that they motionless begets displacement, then this may have then this may be seen as just the hospital's way of harassing people to get off their campus.
Yeah, no, it was interesting when we first brought the idea up, and you know, my goal was to make sure that we had safer drug use and to prevent fatalities. I think when I approached the public safety leadership, they looked at this as like a great way for us to be monitoring whether or not people are using in the bathrooms. And so I tried getting at some of that when we were doing our initial training, looking at some research that showed sort of like why people use drugs in the bathroom, why addiction is considered a chronic disease, sort of some of the brain changes around that. But I still think at the end of the day that selection bias probably played a role, right? And just like wanting to say things that they felt were desirable for society for them to say, right? No one wants to not save someone. But I think it would be really interesting to go back now, especially I know that when I left BMC, they were planning on expanding the number of these alarms to other sort of isolated bathrooms, single occupancy bathrooms on campus. And so it'd be interesting to see now that they have more of them, what that response from public safety is, and if it's still favorable.
And no, thank you. And the last thing I'd suggest is not to limit this to this. I mean, single occupancy bathrooms are appealing, but stalls are a place where I know as someone who worked in public safety, I've responded to overdoses in stalls.
Yeah.
And I was thinking as you were talking, they have that sensor that knows when to flush when you sit down. Like that tells you that somebody's that tells you that someone's in the stall. That with an overhead motion sensor could be combined. The stall is occupied and no one's moving, could be a way to bring this to the stall level. And I was so impressed with how elegantly you designed the system for the single occupancy that it got me thinking of ways to use that elegance to go to stalls as well.
Yeah, I think that that would be wonderful. We had a lot of pushback from the electrician when we started thinking about, could this be applicable to stalls? And so I sort of just was like, well, let's get it in 3 bathrooms first and see how it goes. But I completely agree. And, you know, I was talking to someone recently and it had nothing to do with drug use. It had to do with BLS and ACLS training. And they were saying that if you are going to have a heart attack, you want to have a heart attack in Las Vegas at a casino. And the reason for that is because they have all of these video recordings looking at you when you're sort of on the floor, but then they ran into this issue where people would go into the bathroom and then they'd have a heart attack in the bathroom and they had bad outcomes there. And so they actually have stall-based motion detectors in bathrooms, in casinos in Las Vegas. So I think it's doable.
There you have it. Yeah.
It would be worth like talking to someone who works in like casino business, I guess, and see if we could learn from them, right? Because if they can do it, we can do it.
I am curious if other, thinking about other industries, but have you shared, or since your paper's been out, talked with other hospitals, who are thinking about, especially for their or other locations with single unit occupancy restrooms, single stall.
So I haven't heard specifically from individual hospitals. I know that there are a few other programs and community health centers in the BMC system that were interested in implementing something like this. You know, I think that each hospital environment is a little bit different. For example, at OHSU, we don't have a large number of overdoses in the hospital, surprisingly. And so if I were to propose this in some of our single occupancy bathrooms, I think that they would say, well, we don't need it. And so, you know, I don't know if other people are doing this, but I have not specifically had any correspondence with places interested in implementing it.
I'm thinking about the airports. In both in Rhode Island and Massachusetts, we have a lot of single stalls and actually a lot of overdoses that over time that we've tracked in those locations, and other places that have tracked non-fatal and fatal overdoses in public spaces and have good defining data there. But it strikes me it would be something that airport security aren't regularly on, looking at the bathrooms, but that have, when this happens, or other transportation hubs. But I actually was curious, I know kind of the multi-stall bathrooms in that space, the single stalls are all on one floor and the multi-stalls on the bottom, with very few overdoses in the multi-stall and many more in the single stall. Is it just a matter of open design, or do we need technology? Why not just make them all multi-stall? But
Yeah, I think, yeah, I mean, it could be, I think the big issue would be determining when someone was in the stalls. Because we had a hard time. So we had to go through 3 or 4 different types of motion detectors in the single occupancy bathrooms to find one that was sensitive enough that it would actually sense movement. So we would actually try it out. I was like in the trial period, I would just go in there and sort of sit on the toilet and not use it, and just make sort of some normal movements and see if the alarm would or would not go off. And I think that I don't know of a single way of doing that, because of the stalls would just sort of like block the motion. Maybe if you had multiple motion detectors that were all triggered to one, it might work, but yeah, I don't know.
Gordon, you look like you're going to say something.
Is that how I always look? I know. So my colleague Sampath is on the call, and we're actively looking into what the design of multi-stall monitoring would be. But I think one of the other questions is like maybe people aren't using so much in multi-stall because they don't feel the same sort of level of privacy and safety that they'd feel. So as you're saying, Tracy, like it's always this question: is it design? And we don't want to design around pushing people away, right? So let's not design to solve the problem that way. But is there a way we could keep people safer in all of these environments? And yeah, I'm asking more questions.
Yeah, I mean, the other thing that I sort of thought about with so like the first floor of this building, the multi-stall bathrooms are busy. Like people are going in and out a lot. And so most of the time when and again, this is not backed up by evidence or data, but when I spoke to public safety officers and asked them sort of how did you find people who were overdosing in these busy multi-stall bathrooms, usually someone would come out and say, I think someone is not doing well in the bathroom because their leg has like shot out from underneath the stall and they're not moving, right? And so then they would alert public safety, who would go in and respond pretty quickly, just because the volume of people who are going in and out of those bathrooms sort of didn't allow for someone to be down for 13 hours before they were found.
A couple specific questions about just other access and other potential Good Samaritans and other access to naloxone in the environment. But could you share a little bit about whether, since the alarm was extremely obvious, did other people other than public safety respond in these instances, and what happened in them?
Yeah, so not to my knowledge. Usually the officers were right there. You know, when I talked with them, they said they could get up from the info desk that they were often sitting at to the bathrooms in about 20 seconds by taking the stairs, because it was just one flight of stairs up. And so it usually was just public safety, at least to my knowledge, that responded. Again, if it was someone else, they wouldn't have filled out one of our response forms most likely, but I would think that in those forms, public safety would have mentioned that they were sort of second on the scene, and I didn't see any of that.
I think that also speaks to the need to think about how we disseminate an alarm or other harm reduction intervention like this, right? Because the general public may not know why the alarm is going off, right? It's a hospital setting. So if you are a patron of the hospital, you're there for, you know, someone that you're caring for, or you're there for some other reason, an appointment. If you hear an alarm going off in a hospital, I know as a non-medical person, I'm going to be like, oh, that's an alarm for a doctor or a nurse. That's not an alarm for me. Like, I'm going to ignore it unless it's like a fire and then I need to leave, right? So I think maybe we could think about how do we educate the public with postage or signage, sort of saying this is a potential overdose situation. Here is, you know, naloxone in a kit, kind of the way you would find it in some locations, although we don't have those in the hospital, do we, Bradley? Mm-hmm. I don't think naloxone's widely sort of distributed.
No, and
but that might.
And I think that there was a question in the chat box about, was there Narcan on the wall? And the issue with that, when I brought it up to hospital leadership, was that it's a prescribed medication and you can't have a prescribed medication out available to the public. It has to be under lock and key or in possession of someone who can utilize it. And so we got around that by all of our public safety officers carry Narcan and have to be trained in using Narcan. And then they also had, they called it their first response bag. It was like a red duffel bag that had the ambu bag. It had the face shield, it had more Narcan, it had sort of Band-Aids and gloves and all of that stuff. But it was not sort of on the wall available for anyone to use.
The question around Sharp's containers too, in terms of like providing other harm reduction services and a safe use material and kind of signals to people that it was safe to use there? Were there in all of the stalls or in other parts of the building ways that people could dispose of syringes?
So in those bathrooms in particular, there were sharps containers in each of the bathrooms. I can't recall off the top of my head if I think recently the institution had made it a goal to ensure that there were sharps containers in all of the public restrooms, which was fairly new for the institution. But that was my recollection. I don't know for sure 100%, but I know in those bathrooms that had the anti-motion alarm system, they had access to sharps containers.
So I am curious if the conversations with colleagues and maybe with the public safety and otherwise kind of spoke of overdose prevention sites or say consumption spaces along this larger continuum, and certainly CFMA now, and there are many larger conversations in Massachusetts around consumption spaces and Spot being right across the street. How did this particular alarm-based system kind of fit in that larger conversation? And maybe you know this or not, but Rhode Island has many a time, and many on this call, we've been looking at, researching, thinking about safe consumption spaces for Rhode Island. So just as context.
Yeah, I don't know where this sort of would fit into that conversation. I think in sort of like our approach, right? Like I would love to see a safe consumption site at the hospital. There were times when I was caring for patients and they left the hospital without completing treatment because they weren't able to use. And then sort of, that results in poor outcomes for them. But I don't foresee the institution implementing that anytime soon. And sort of this was a way that, we had noticed that there are people who were dying in these bathrooms that shouldn't be dying in bathrooms. And so we tried it out. I actually would be interested to see if people had any comments about how this would fit into safe consumption sites.
I don't know if others have thoughts on this. One of many of the tools, perhaps. See, it looks like we have a number of people talking about the overdose prevention sites that are in Vancouver, which is awesome, both proximal to the hospital and operated elsewhere, but not necessarily within the hospital setting. And I think there are a few that are in operation in the hospitals. Let's see. I'd probably be also remiss if I didn't share about, I'm not sure if conversations around nalox box is one of the interventions that have kind of birthed out of Rhode Island, but kind of naloxone easily accessible on the wall with emergency notifications and otherwise kind of built within. But this is more complex with an alarm system based on motion censoring, and it could be a lot of hardware on the wall with naloxone there too. But just as another aspect of the design, perhaps in the co-located space.
Definitely.
I was wondering. Oh, sorry, go ahead.
Go ahead, Bradley.
Oh yeah, I was just gonna say, yeah, definitely. I think that there's plenty of wall space still in the bathroom for us to put Narcan there. And so in my general opinion is the more Narcan, the better. So at least more access to Narcan, I should say, the better.
Yeah, to that point, I was wondering if others on the phone could comment about whether or not their public safety officers are carrying naloxone or willing to administer naloxone, because, that's sort of a newer thing that is happening in some places, but not everywhere.
I can tell you that at our institution, our public safety personnel are actually Oregon State Police, and they do not carry naloxone.
Hmm.
Do they have a reason why they won't?
I don't know if it has to do with union stuff, but I don't know specifically if there's a reason.
In this case, you have a really kind of a unique group of people with public safety officers with the opportunity to who really kind of see it as their job as caretakers of the hospital setting, and really have really embraced all aspects of their environment. I'd wondered too, like in some ways, with lacking that alarm, that it's not just their workflow, it's the feeling of, another patient or another patron in the community that they, how long were they in there, and that sense of like they should have or they could have potentially have done something differently, but they probably didn't also sign up to be a bathroom monitor. That's this intervention.
Well, what was so interesting about that is when public safety officers spoke about this being an acceptable and sort of appropriate part of their job responsibilities, in these comments, and we didn't have so much time to get into the details of it here in this presentation, but they also spoke about acknowledging the location of Boston Medical Center. It's in an area that has had some horrible stigmatizing nicknames that don't need to be repeated, because it's a central location for a lot of substance use treatment services and harm reduction services. And so they sort of recognized, hey, we work not at any hospital, we work at this hospital in this setting with these clients. And so we owe it to our community to respond appropriately to the needs here.
And when I first started the project, I actually was interested to see what the impact of fatal overdoses were on their response, like first responders and fatal overdoses. But when we talked with the public safety officers about it, it didn't seem to be something that, like, they didn't have guilt over anything when we brought it up. They didn't feel like, they actually were just like, well, we did our training, we did everything we could. The nice thing about these alarms is, like, when they go off, we know that person has only been down for 4 minutes, versus, before these alarms were implemented, these bathroom doors were either locked and no one had access to use them, or they had a camera on the ceiling that someone was intermittently monitoring to see when individuals went in and how long they were in there. But if that officer was sort of like on a break or had to get called away, then he wasn't really watching it. And so the fatalities that we saw were actually, the individual went in at the end of the day and then was found the following morning when they unlocked the bathrooms. So, I think from a time perspective, even with the false alarms that were potentially going off, public safety thought that this was a great intervention, because before they would have to sort of do every 5 to 15 minute checks of the bathrooms and knocking on the doors and watching the video. And so they felt like this was an acceptable alternative, which I think is probably better for, outcomes and for their ability to, get other things done throughout the day.
I was thank you so much for the presentation. It was really wonderful. And I was thinking about what's been going on here in Rhode Island, and we actually have all law enforcement who maybe not each individual law enforcement officer across the state actually carries a naloxone, but each department has signed on to do that. But of course, public safety officers there's so many different across the state, and that's very much whoever wants to take that on. And I know that a lot of different groups have reached out to me to say, okay, would you provide us naloxone, do training? So yes, that's great. But I love this presentation because this is really great to be able to share with places like I don't even know if here at the Mirror, I don't know if Lifespan hospitals, all the public safety officers are carrying naloxone. I don't know, Tracy, if you know that, but so this is a great way to say, oh, look, this is being done and it has really good outcomes. Even though it's different, it's the same vein of well, and you know, it's specifically about responding to the alarm in this way, but it's sort of like we see this life-saving thing as critical to our mission. So thank you, because it'll be great to use in reaching out to public safety officers.
Thank you so much, Michelle. I am so sorry. I have to jump to another meeting right now, but I think Bradley is staying for a little bit longer. But it was so good to see you all. Good to see you, Michelle. And thank you just so much for sharing your time and ideas with us today. It's been really helpful. I have lots of sticky notes with new ideas written down on them.
Thanks, Erica.
Bye.
Yeah, I think thinking, Michelle, just to what you just shared too, this research seems like it was extremely possible because there were actually data that the hospital had been collecting on overdoses that occurred on site. So it wasn't just, oh, I heard there was an overdose in the bathroom here or there, but it was actually like, yes, we've had this many overdoses and this many have been fatal and this many have been non-fatal. This is the time, this is the day, this is the location, who responded, Narcan was given or not. It's the same data we collect in the community, but it's actually in the micro environment of the hospital, kind of a hotspot, if you will, within a larger hotspot, but then treated like a possible place of preventive intervention. And but that data, I don't know, you're sitting in another hospital now. I'm curious, do you see these up, and not you don't have to throw anybody under the bus here, but just thinking like, is there room for leadership for other hospitals to start to think about both public safety responses, but also just health emergencies like this? Overdoses happen all the time. I think they're the most common adverse event, I guess, on most hospital environments, naloxone being the most common medication administered. But in this case, it's with a very specific outcome.
Yeah. So I have to thank Alex Walley for setting up the overdose sort of monitoring that Boston Medical Center was doing. And he would get quarterly reports on sort of overdose numbers, where they were, if there were fatalities. And so that sort of was where it all came about. And it's like, people are dying in bathrooms in a hospital, which is supposed to be one of the safest places, you know, for individuals who are seeking care. How can we prevent that? And so that was in place, fortunately, and I think they're continuing to report those. I can tell you, to my knowledge, the hospital that I'm currently at, they do not report those overdoses, but I think some of that also has to do with the fact that just like where the hospital is located, it's sort of an isolated area that it's not easy for people to get to per se. We definitely have overdoses in the hospital, but not most of the overdoses we were seeing in our single occupancy bathrooms at BMC were not individuals who were at BMC for treatment that day. They were individuals who were looking for a isolated, warm, safe environment where they had access to good lighting and privacy and clean water, and wanted to use a substance one way or the other in an area that sort of gave them some decency to do so. And so when you look at the evaluations and the overdoses that we had, most of them were not people who were admitted to the hospital or who even were there for clinic visits. And so I think that is also interesting, and I think makes a huge difference when you're thinking of sort of implementing something like this, right? It's very different if they're a patient, because then you can call a code and then people can show up and they know who the person is and like what their medical history is. Whereas in these scenarios, often we had no idea who the person was until they came to after they had gotten Narcan. And so I think that sort of sets the stage well for public safety personnel to be first responders in these scenarios, because they don't need to know all the extra information.
We had a question from Teresa asking if you had follow-up plans, follow-up research plans, and if you and or Erica are working together, or the larger hospital itself. It seems like a good risk management pilot project underway, but something more?
No, I mean, I would, so I do not have any plans to continue the research, but I know that the institution was planning on expanding and continuing to sort of improve on the devices themselves in different bathrooms and in different buildings. I would really love to do a quantitative assessment looking at, false positives, false negatives, and then potentially even looking at, once we have that information, what's sort of the cost, right? The time cost, the monetary cost, the lives saved, right? All of those I think would be very interesting to know, especially if you're trying to convince your institution to do that. Having that data would be really important. But when we started the project, there were just so few overdoses that to get some statistically significant data from like a quantitative perspective, I think would have been more of like a 3 to 5 year project. And I was only doing a 2-year fellowship. So we had to start with the qualitative stuff and go from there. But I think, figuring out that time, right? Is it 4 minutes the sweet spot? Is 3 minutes the sweet spot? Is it 5 minutes? Does it depend on your institution? Can we get these alerts sent to cell phones? All of those things I think would be really important for dissemination in other environments.
Yeah, great. And hearing from the participants and people who are patronizing the voices of people who use drugs in the experience that's there. I think we have a couple of really great suggestions and postings from in the chat for other reports and opportunities to see research that's being done and conversations that people have been having all over North America, which is great on this. And I think you're sharing around people patronizing that particular space being more from the community, and recognizing that there are many patients in the hospital who also very much need a safe place to inject, and if that is their room, and trying to reduce overdose risk in those environments as another very common challenge that responding to patients, and the need for potentially conversations about a safer washroom at a hospital.
Mm-hmm.
So thank you all for those great insights. Any other thoughts or questions for our speaker today? Or if not, we can also continue the conversation in electronically, and also we have Bradley's contact as well as Erica's contact.
Yeah, happy to answer any questions via email if they arise in the future.
Great. Well, thank you everyone for joining, and this is our first 2021 speaking event for the COBRE. Please do keep a watch for our future events, and thank you so much for coming, and we'll look forward to seeing what comes next with this.
Yeah, thanks everyone.